All attendees are in listen-only mode.
Hello, everyone. My name is Melissa Larson with the Cardio Group. I appreciate your time. We are going to cover plethysmography, accelerated plethysmography, frequency domain analysis. We are then going to wrap up with the max pulse recording. So we're going to cover the technology of the max pulse, which is pulse wave analysis, and obviously the reporting, but also the economics of using the max pulse clinically in your office, and how it can obviously provide more objective data to use as a roadmap in terms of treatment methods. The max pulse device, the reporting is going to help us arrive at a wave type. We're going to see our mean heart rate. We're also going to be able to detect any artifact heartbeats. We're also going to test the autonomic nervous system, looking for a sympathetic parasympathetic balance or imbalance. By way of the wave type, we're going to also arrive at an eccentric constriction score, an arterial elasticity score, and last, the remaining blood volume score, which we'll cover in more detail. First and foremost, when we look at the technology of the max pulse, we're using plethysmography, and the blood has a pulse wave, and so what we're doing with the device is picking up the blood's pulse wave in real time, and then taking the second derivative or the second differentiation of the baseline wave. This is how we arrive at our accelerated plethysmography technology, also known as mapping the entire cardiac cycle into a waveform pattern. So any pulse wave analysis device is going to be using plethysmography and generally accelerated plethysmography. So across the board, using that technology in any pulse wave analysis, the max pulse, we just dialed it down to a 3-minute test. And then we obviously, as we get into this, you'll see we added population data, and we're also using another technology, frequency domain analysis. So in terms of setting the patient up for a test, we want to make sure that the patient is resting left palm flat on a table. The finger probe is attached to the left index finger with the cord on the top of the finger. Again, this is a quick 3-minute test. There are a few important key points in terms of the setup. First of all, we're measuring blood flow, so we have to have blood flow, which means we can't have a patient that we test that's cold. So we need to make sure that they're warmed up. That left index finger has blood flow to test. We want to make sure that the patient does not have acrylic on their nails. Fingernail polish, gel, shellac, all of these types of chemicals are fine. It's the acrylic that messes with the LED reading. Also, when we're testing the vessel state and vascular compliance, we want to make sure that the patient hasn't consumed any caffeine. Caffeine, we know, is a vessel constrictor. So we want to make sure that at minimum the patient hasn't had a vessel constrictor in the last 2 hours. Some of our clients that are a little bit more strict, they make sure that a patient hasn't had a vessel constrictor within 4 hours. So it's up to you. Just make sure and pick one, and make sure that the staff make sure they're not running any tests, because obviously that vessel constrictor is going to interfere with that compliance score. Now, after the patient is set up, we do enter their name, their date of birth, and their gender. We see the screenshot here. This is what the staff member is looking at while the test is being run. We see that we have our resting heart rate in real time. This PTG wave, this is the blood's pulse wave, also being picked up in real time. That second differentiation, accelerated plethysmography. This is the technology of mapping every single heartbeat, the entire cardiac cycle, into a waveform pattern. There are 7 types of waveform patterns, and every heartbeat is going to fall into one of those types, which we'll cover in a few minutes. We've got our resting heart rate being plotted on an XY axis. We obviously want to make sure that the patient has some level of variability in their heartbeats, because at that point we know that the patient has a more adaptable cardiovascular system. The heart rate variability tachogram here, we're using what's called frequency domain analysis. So the device is picking up an electrical impulse that's being generated from the right atrium of the heart, and we're going to measure how strong or how much amplitude is behind that impulse. Now, after 3 minutes, the device is automatically going to proxy to the first page of results. We see our report 1. These are the cardiovascular risk factors that generally a patient's not going to feel. We're going to go over reports at the end of the webinar, and there are 4 reports where the patients had ideal blood pressure and ideal lab results, cholesterol within ideal range. And we'll see that we were able to pick up atherosclerosis progress, plaque in the radial vessel, looking also at endothelial function. This is the component of the test where we're able to gather data and treat. And also, this is where we're going to gather data and prove medical necessity for upper level diagnostic testing. We see this patient had 99.1% of their waveform patterns fell at type 2. We see that the ideal wave type in light gray, type 1, these are considered perfect heartbeats. And the blue wave here shows that the patient majority fell at type 2. We also see that the device grabbed data from these 5 points from the patient's waveform pattern. These data points are very important because these data points, along with the mathematical equation, are how we arrive at our eccentric constriction, arterial elasticity, and our remaining blood volume score. DPI stands for differential pulse wave index. It's important to know that in terms of the waveform patterns, whether you're 80 years old or 20 years old, you want as many type 1 waveform patterns as possible. Over here, there is population data at play. So this patient was ranked up against his peers in North America in terms of contraction power, vascular compliance, and remaining blood volume. If you see here, normal range is 30 to 70 points. So 34.33 puts this patient at the low end of normal range. And we know that we do not want to score on a cardiovascular diagnostic test on the low end of normal when we're being ranked up against our North American peers. Because obviously what's considered normal is that half of our peers are going to have a cardiac event and become a statistic due to this disease. So we move from the report 1, this plethysmography technology. We have our definitions here that you can view. All of this data is in our clinician training app that can be found on our training site. And now we're at our report 2. Our report 2, it's important we understand first it's a different technology. This is frequency domain analysis. Report 2 is also an environmentally driven component of the test. You see we have our high heart rate and our low heart rate and our artifact beats. This is where the device is going to pick up any irregular heartbeats. If a patient has some type of an arrhythmia or an AFib patient, this is going to show up in the artifact beats. We see that we have our very low, low, and high frequency. This is the technology of frequency domain analysis. So when we're with a patient and we make sure they understand that every heartbeat's electrically generated And now we tell them that we're measuring the amplitude or the strength behind that electrical impulse. Most of them understand that we want strong electrical power. We want amplitude behind these 3 frequencies. These black eye bars do not move. Standard deviation. What's going to move are the graphs. The taller the graph, more amplitude behind that specific frequency. Now, we see this patient, physical stress is high. Physical stress correlates to the amplitude or the strength of power behind these frequencies. We only have 1 frequency out of the 3 that's registering. When the graph touches this eye bar, that's the language we use, that frequency is registering to or not. So we have weak power, weak amplitude. And when we have weak power, that correlates to an increase in the physical stress. TP is the average of the 3 frequencies, and that stands for total power. Physical stress has an inverse relationship with stress resistance. We obviously want low physical stress and very high stress resistance. Now, we're going to arrive at the autonomic nervous system. We see here it's fairly balanced. We're arriving at this by way of the frequency domains. Your high frequency is a parasympathetic driven frequency. Your low frequency, very low frequency, are sympathetic driven frequencies. Because there is a balance in the autonomic nervous system, we see there's a little bit more parasympathetic drive here. There is a decrease in mental stress. When we see an imbalance, many patients are sympathetic driven. That is going to elevate this mental stress score. This is a waveform patterns document. We use this document when we're educating the patient because if they know nothing about waveform patterns, which many of them don't, they can at least see visually that this type 1 waveform pattern, this heartbeat, looks much different than these type 6 and type 7. Obviously, we see the progression of buildup, atherosclerosis progress. We know that no matter what our age, we want as many type 1 waveform patterns as possible. Type 1 and type 2 is ideal. Type 3 to 7, we have atherosclerosis progress in the radial vessel. So now, obviously, great time to test the carotid because we want to see how much plaque is in the carotid. This is also where the clinician will implement a treatment protocol because we're going to arrive at a baseline test. We're going to do everything that we can clinically to improve circulation and the state of the vessel. This frequency domain analysis document is also used to educate the patient on what a healthy frequency domain looks like and an unhealthy frequency domain. We see we have weak power and we have a lot of amplitude, strong power coming from the SA node. That very low frequency is a sympathetic driven frequency, but it also correlates to body temperature regulation and hormone function. So a lot of our clients will test a patient, and if this very low frequency comes in weak, we know that we have the ability to prove medical necessity for any test to check the thyroid, running a thyroid panel blood test, thyroid ultrasound. The Max Pulse Report 1 and 2 prints on one PDF document. You can also use the Qt PDF Profiler to download into your laptop and move this to your EMR system. The Max Pulse patient education brochure contains, this is the document inside of the brochure. We found that being able to lay out this test in lay terms obviously takes a lot of time. in terms of education frees up a lot of time for the clinician. This is also a great document to not only have in your waiting room, but to have up on your site. So a patient will walk out of the office with a printout of their result, and they'll be able to refer to that on your website at all times. We have your definitions of the vascular aging process. Most important that we understand that these metrics are being derived from the waveform pattern. If we improve the wave type, we're going to have better data points, and better data points along with that mathematical equation, we're going to improve our eccentric constriction, arterial elasticity, and remaining blood volume. Now, physically, when we improve endothelial function and state of the vessel, obviously the body doesn't have to apply as much force to circulate blood. We improve the waveform patterns, we're taking stress off the body has to apply less force to circulate blood, and therefore we're improving our contraction score. Obviously, when we help the body naturally remove plaque by way of nitric oxide synthase, releasing nitric oxide through the endothelial cells, we're going to arrive at a more compliant vessel, therefore improving that arterial elasticity score. And just as we improve the contraction score, we're going to improve that remaining blood volume, because we're looking at how good of a job the body is doing at rebounding, wrapping up the cardiac cycle, making sure all the blood leaves so it's efficient, but also doing it quickly. We have a breakdown of our sympathetic and parasympathetic nervous system. Obviously, balance in the autonomic nervous system is important, because that autonomic nervous system is communicating to our internal organs, telling them what to do. And when we have a balanced autonomic nervous system, it's communicating more properly with the rest of our body. Here's a breakdown of the very low, and high frequency. So you can see that this band of power, everything from 0.0033 to 0.04 hertz, falls in the very low frequency domain. Total power, average of the three frequencies. And now we move to our first sample report. So these 4 sample reports that we're going to cover, it's important to understand that a lot of our clients, when they're brought on as a client, they're really leaning on blood pressure and blood chemistry. And I think it's important that we obviously highlight that these 4 reports are from patients that blood pressure, ideal range, and blood chemistry, looking at cholesterol, was also in ideal range. And we know that according to the American Heart Association, 2,200 people died today from a heart attack or stroke, and half of them had no symptoms. So that right there tells us that, first of all, we have got to do more testing, more objective testing. We've got to gather more data. And if we're just going to use the max pulse to sharpen our sword in terms of treatment, that's great. If we're going to use the max pulse device and all of the data that it's generating to prove medical necessity for higher level testing, obviously that's even better. So we see this patient, majority of their waveform patterns fell at type 2, but we also see what's happening. Type 3, type 4, type 5. So we see the trend moving towards these higher level waveform patterns. We also see that this patient, arterial elasticity, while being ranked up against her 48-year-old female peers, coming in at suboptimal 14.77 points, we know that our vascular state, our vascular compliance isn't going to improve with age. And so to already be testing on this low end, this suboptimal range, in terms of the integrity of the vessel, we know that we did not pick this up in a blood chemistry test, and we know that the blood pressure is fine. We know that we've got atherosclerosis progress, so we need to treat in any fashion that you feel philosophically is in your wheelhouse in terms of pharmaceuticals, whether it be diet, lifestyle. Many clinicians will remove inflammatory foods, use a pharmaceutical to manage the disease state, and on top of that, add an amino acid that's going to help release nitric oxide through the endothelial cells, then vasodilating the vessel. This patient is obviously a candidate due to the waveform patterns for carotid. Obviously, if we've got this plaque in the radial vessel, we want to find out how much is in the carotid. This should also flag the clinician to ask the patient if they're feeling shortness of breath. Many patients will go in and see their doctor and they won't tell the doctor that they have any shortness of breath because they're not used to exerting themselves. The chances of a patient from type 3 to type 7 having shortness of breath, that is typical. And obviously, if we have shortness of breath, now we have the ability to run a cardiopulmonary exercise test. We can see if we're dealing with ischemia, and we can see if that shortness of breath is due to deconditioning or if it's clinical. We see this patient had elevated mental stress. This patient's in sympathetic drive. That high frequency, which is the parasympathetic driven frequency, is barely registering. And the very low and low frequency are coming in nice and strong. So 2 of the 3 are coming in strong. That's why we're arriving at physical stress that is low. And the mental stress obviously high due to the imbalance in the autonomic nervous system. Our second report, we see that we picked up 5 artifact beats. That's generally not enough in terms of if the patient has an arrhythmia. Generally, if a patient has some sort of an arrhythmia, AFib patient, those are generally 20 and higher. But we do see that we have a high resting heart rate. We see that we've got majority type 3 waveform patterns, type 4 and type 5. Across the board, this patient being ranked up against her 52-year-old peers, eccentric constriction score, a low end of normal. Arterial elasticity, low end of normal, and our remaining blood volume, again, on the low end of normal. So we've got atherosclerosis progress. So again, we can prove medical necessity for an upper level test. We know that we can implement a treatment protocol, and we're going to retest in 90 days. We see that in terms of the frequency domain, this low frequency is coming in nice and strong, very low, not quite registering, high frequencies coming in at weak or low amplitude. So because the very low and the low frequency are your sympathetic driven frequencies, high frequency, parasympathetic driven, we see this is how we arrive at a mental stress score that is high due to an imbalance in the autonomic nervous system. Our report 3, obviously this patient, we've got lots of work to do. Type 5 waveform patterns. Eccentric constriction scores obviously taking a hit. Most patients understand that the body is going to have to apply more force to circulate blood, which can be rigorous on the cardiovascular system due to buildup in the vessel. Type 5 waveform patterns, the eccentric constriction score coming in at suboptimal, our arterial elasticity is coming on the low end of normal, remaining blood volume, suboptimal range. This patient, I can almost assure you, shortness of breath If they are exerting themselves, absolutely, we will see correlation between type 5 waveform patterns and some level of plaque in the carotid. We move over to our frequency domain analysis. All three frequencies are registering. Autonomic nervous system is fairly balanced. Physical stress is normal. Mental stress is normal. Stress resistance is normal. I pulled this report because it's very important for patients and the interpretation process that they understand that there's two different types of technology at play. Many of them gravitate towards stress scores because they feel they understand it. We do not want a patient leaving the office with this report, seeing that their physical stress, mental stress, and stress resistance are all in normal range, and they have a fairly balanced autonomic nervous system, and because they think they understand that better than waveform patterns and the cardiovascular risk factors, we do not want them to think that they ace their cardiovascular test. It is absolutely possible for a person, as you can see, to do well on these parameters and not do well on the aging vascular health, their cardiovascular risk factors. And obviously, because this patient cholesterol was in ideal range, blood pressure ideal range, and not feeling any symptoms, it's very rare that a patient's going to feel a symptom from hardening of the vessel or weak contraction score. This objective data is very important because this is obviously what's going to keep the patient compliant, because they're going to follow your protocol and they're going to know that in 90 days we're going to be checking in to run another test and make sure that they were compliant. Our final report, this is a 39-year-old female, type 4 waveform patterns. Now, I pulled this report because obviously this is a patient that has waveform patterns that are not as bad. They're not falling in type 5 like our previous report. But we can see what's happening. She scored much worse in terms of arterial elasticity and remaining blood volume than our previous patient. So let's go over why that happened and how that's possible. First of all, there's population data at play. So our previous patient was ranked up against her peers, her 52-year-old peers, and this female is ranked up against 39-year-old peers. Second, the device is gathering data from 5 specific points, and there's a specific mathematical equation that helps us arrive at these metrics. So these two patients, their data points that were collected could have been different. And then obviously you add on top of that the population data. We see this patient's arterial elasticity and remaining blood volume scores coming in at 2 points. We see that the eccentric constriction score is coming in at 59. It is absolutely possible for a patient to have strong contraction and have hardening in the vessel. So this patient obviously did not do well in terms of cardiovascular risk factors. And then we move over to the frequency domain and the autonomic nervous system. And again, they did fairly well. 2 of their 3 frequencies are registering. What frequencies coming in weak? We see it's the very low frequency. We know that our very low frequency correlates with hormone function. So in terms of this report, we have atherosclerosis progress. We absolutely need to make sure that the patient has a cardiopulmonary exercise test. And we can also look at a thyroid panel and a thyroid ultrasound because of this very low frequency. These two are coming in, registering nice. The very low frequency is showing weak amplitude. If anyone has any questions regarding the Max Pulse technology, the training, the support, any marketing support, anything that I covered on this webinar, you'll see this is my contact information. Much of the research on plethysmography is on our training site. You see maxpulsetraining.com. We have about 16 research articles. There are hundreds of research articles on plethysmography. Pulse wave analysis has been used clinically for over 30 years. Again, we're just taking that data that's being collected analog to digital. We dialed it down to 3 minutes. We added frequency domain analysis and some population data to our reporting. The economics of the device, obviously, many of our clinicians are charging cash for this service because they may be in a concierge environment and or an integrated practice where they're not dealing with insurance. Plethysmography can be billed by Medicare and most private payers. Many of our clients, when we survey them, have told us that if they never collected a dime from insurance or from their patient from the actual test and just took the income in terms of generating more data to provide better treatment, more treatment, improving clinical efficacy. Obviously, that's a great way to market the practice from the inside out. And also all the income that's generated from those upper level diagnostics, because we know we need to gather more data to arrive at those diagnosis codes so that we can offer that higher level testing to the patient. Please feel free to contact me, and I appreciate everyone's time. Have a great day.